Good afternoon, everyone, and welcome. I'm Ellen Lautenberg, Advisory Board Chair of the Mount Sinai Institute for Exposomic Research, and it's a pleasure to welcome you to today's presentation. Today's program is the final webinar in our current series. Over the past several months, we've explored a wide range of important topics at the intersection of environmental exposures and human health. And today's discussion brings us to another critically important area: the relationship between air pollution and cancer outcomes. Unfortunately, we are seeing evidence that certain cancers are increasing, particularly among younger adults. There is growing recognition that cancer risk is shaped not only by genetics, but also by the environments we live in and the exposures we experience throughout our lives. Researchers are increasingly studying how factors such as air pollution and other environmental exposures may influence cancer risk, progression, and survivorship. At the same time, there is also reason for optimism. This research is helping move the field beyond simply identifying risks towards improving prevention, clinical care, and public health action. Air pollution affects millions of people worldwide, making this an important conversation for clinicians, researchers, patients, policymakers, and communities alike. Please use the Q&A function throughout the webinar to submit your questions, and we'll reserve time at the end for discussion. We'll try to answer as many questions as possible. It is now my pleasure to introduce today's speakers. Dr. Yaguang Wei is an assistant professor in the Department of Environmental Medicine at the Icahn School of Medicine at Mount Sinai. His research focuses on environmental epidemiology, that word always gets me, air pollution exposures, and the application of advanced data science approaches to better understand how environmental factors affect human health outcomes. Dr. Hannah Thompson is also an assistant professor in the Department of Environmental Medicine at the Icahn School of Medicine at Mount Sinai. Her work focuses on cancer epidemiology and environmental contributors to cancer outcomes, with an emphasis on translating research findings into improved patient care and public health strategies. We are delighted to have both of them with us today. I will now turn it over to Dr. Wei and Dr. Thompson.
Hi, everyone. Thanks so much for the invitation and the great introduction. And we're really excited to be here to share some of our recent work. And lung cancer is a very unique chronic disease with huge heterogeneity. There's a substantial difference between different types of cancer. And because cancer is such a broad concept, we'll focus exclusively on lung cancer in this talk. Lung cancer is a cancer that poses the largest burden in the US. It is a deadly, most deadly cancer, which accounts for about 1 in 5 cancer deaths. Lung cancer is also an aging disease. The incidence increased substantially with age. About 68% of lung cancer patients are diagnosed after age 65 years, and about 75% of lung cancer deaths occurred in that age group. Most lung cancer cases are not related to genetics. The genetics, including family history, only explain less than 20% of lung cancer cases. This means the environmental factor plays a major role in lung cancer development. And speaking of the environmental risk factors, smoking has long been recognized as the most important one. In addition to smoking, air pollution, particularly PM2.5, is increasingly being recognized as another important environmental risk factor. PM2.5 is a major air pollutant regulated by US EPA. And as you can see from this figure, compared with a human hair, which has a diameter of about 50 to 70 micrometers, the PM2.5 is really small, with diameter less than 2.5 micrometers. PM2.5 are actually tiny particles floating in the air. And once inhaled, they can pass through the lungs, get into the bloodstream, and circulates throughout our body. That's how PNO5 causes various health problems. PNO5 is also a complex mixture of various chemical components. And given the sufficient evidence linking air pollution, particularly PNO5, with lung cancer development, the International Agency for Research on Cancer, or IARC, classified air pollution and PNO5 as group 1 carcinogen for lung cancer in 2013. In addition to smoking and air pollution, radon is another environmental risk factor, which mainly found in our basement. In this talk, we're focusing on air pollution, and that is the scope of our discussion today. A fundamental question to ask is, why care about air pollution? Well, first of all, air pollution is a widespread exposure. It is everywhere, and everyone is exposed. So by addressing the link between air pollution and lung cancer, it provides opportunity for scalable interventions that can have broader impact. Also, most dangerous air pollutants are mainly emitted from human activities. That means air pollution is a highly modifiable and actionable public health target. In addition, the declines in national air pollution trends have stalled since around 2016. As you can see from this figure, these are the national PNO5 levels over the past decades. And in more recent years, the decline in the national PNO2.5 level have stalled. And for some years, the national level even increased. That means we cannot expect the decline in the potential risk posed by air pollution. And the study here represents one of the most recent and largest cohort studies linking air pollution and lung cancer incidence. We did this national analysis of the Medicare cohort aged over 65 years. And in total, we included over 12 million individuals. And we evaluated the 3 major air pollutants, the PNO5, NO2, and ozone, which are all regulated by US EPA. We also evaluated the particle radioactivity, which is a measure of the radon exposure. We found that the chronic exposure to PNO5, NO2, and particle radioactivity were significantly associated with increased lung cancer incidence, except for ozone. And the results are pretty consistent and robust across different types of analysis. And this study provides an important addition to the existing literature, with a nationally represented population and a focus on older adults, which is highly relevant for lung cancer. Among all the air pollutants, PNO5 is a little different. It is a complex mixture of various chemical components. So our next question is, which chemical components matter? This is a critically important question because if we know PNO5 is harmful, we need to control for it. But how? By answering this question, we can provide a solution. From this figure, you can see this is an example of typical PNO5 composition. It mainly consists of sulfate, nitrate, ammonium, some carbonaceous contents, in organic compounds, some metals, and other stuff. The toxicity of PNO5 is really determined by the chemical composition. For example, sulfate has been found to be extremely harmful for cardiovascular health, while some heavy metals have been identified as group 1 carcinogens. So in this study, we evaluated the effect of 15 PNO5 components and lung cancer incidence. The PNO2.5 components we evaluated include carbonaceous contents in organic compounds and metals. Overall, these components represent the majority of PNO5 and are considered most harmful for human health. Again, we perform a nationwide large-scale analysis of all the Medicare beneficiaries aged over 65 years. In total, we included over 15 million individuals. We found that vanadium, or V, clearly stand out. it has the largest weight among all the components contributing to lung cancer incidence. So with this finding, the vanadium is an important heavy metal pollutant. It is a marker of heavy fuel oil combustion from sources including shipping, commercial building heating and cooling system, and petroleum refineries. So our message is very simple and clear. Vanadium, which mainly emitted from shipping, commercial building heating and cooling system, and petroleum refineries, appear to be a major contributor to lung cancer development. Now we have defined the relationship between air pollution and lung cancer incidence. Another important outcome to consider is mortality or survival. When we talk about cancer, we mainly talk about incidence and survival or mortality. So our next question is, how does air pollution affect mortality after lung cancer diagnosis? Why focus on mortality? Well, lung cancer is a leading cause of cancer deaths. And compared to incidence, the lung cancer mortality is relatively understudied, but it is critical for understanding prognosis and lung cancer management. Also, compared with the general population, lung cancer patients may be more susceptible to air pollution because of the compromised lung function and treatment-related side effects, such as immune dysfunction. Also, in addition to the mortality effects of air pollution for the general population through established pathways, for example, through the effect on cardiovascular and respiratory systems, air pollution may also contribute to lung cancer progression, as we have shown that air pollution is related to lung cancer development. So this is very likely to happen. So this created additional pathways that affect the lung cancer patient survivorship. Overall, it is very likely that lung cancer patients are particularly sensitive to air pollution. From the exposure side, the wildfire smoke has emerged as an important but ignored environmental risk factor. The evidence from animal and toxicological studies suggests that wildfire smoke PM2.5 may be more toxic than non-smoke PM2.5 because of the smaller particle size and higher carbonaceous and metal contents, which have greater potential to cause oxidative stress and inflammation. At the same time, the wildfire smoke is becoming increasingly relevant. As you can see from this figure, the area get burned by wildfire in the US has increased substantially over the past decades. As we mentioned, the national PM2.5 level has stopped declining or even getting reversed. A key driver behind this is wildfire smoke. The study here shows that the wildfire smoke is becoming an increasingly important contributor to the national PM2.5 trend. This is not a problem just for areas near the wildfires, such as California. The wildfire smoke can remain in the air for a very long time and travel thousands of miles, which affect large areas and has offset the progress we have achieved through the traditional air pollution control strategies. So we did this cohort analysis to evaluate the wildfire smoke PM2.5 versus non-smoke PM2.5 on mortality following the lung cancer diagnosis. And we included over 400,000 lung cancer patients from the SEER Medicare database, which include all the Medicare beneficiaries diagnosed with lung cancer in the SEER regions, which represent about 50% of the US population. And this study also have important implications for lung cancer management because we focus on mortality after diagnosis. And our finding is striking. We found that wildfire smoke PM2.5 has substantially larger effect than non-smoke PM2.5. And if you look at this figure, this is an exposure response relationship between PM2.5 exposure and mortality risk. And the curve for the wildfire smoke PM2.5 is much steeper than non-wildfire PM2.5. And to put this into perspective, although the average concentration of non-wildfire PM2.5 is about 24 times higher than that of wildfire smoke PM2.5, the corresponding mortality burden was only 5 times greater. So our message is that wildfire smoke is very dangerous, and with its high toxicity and the status as fastest growing contributor to air pollution, we think we should take into account the wildfire smoke exposure into the cancer management in lung cancer patients. A common question to ask is should we consider wildfire as a natural event? The short answer is yes, but with important caveats. Some wildfires do occur naturally, for example, through lightning. But most wildfires are triggered by human activities. Things like electric power lines, campfire, even a cigarette butt that did not put out properly can start a wildfire. The climate change adds another layer. The warm and dry conditions are making the fire season longer, increasing the wildfire frequency and intensity, as well as the area get burned. And as a result, the wildfires are releasing an increasing amount of air pollution. Unfortunately, such increasing and significant amount of wildfire smoke is excluded from regulatory attainment determinations. Under US EPA's regulations, the wildfire is considered a natural event and therefore are excluded from beyond the control of local authorities. However, as we can see here, most wildfire are triggered by human activities, and wildfires getting increasingly intense because of climate change, which is directly related to human activities as well. Therefore, the interventions to reduce wildfires are entirely possible. With that, I will hand it over to Hannah.
Thank you so much, Dr. Wei. I feel like I learn something new every time you speak. Your work is really, really impactful in this area. So now I'm going to spend a little bit of time just talking through ways that we can protect ourselves and our patients from the harms of outdoor air pollution. So next slide. Perfect. And so, as Dr. Wei sort of mentioned, the ways that we protect ourselves and our patients are multi-level and need to be multi-level. They need to start from the system and policy change in the local and national arenas. But also, as Dr. Wei really nicely laid out, there's also increased vulnerability in cancer patients and lung cancer patients to outdoor air pollution and wildfire smoke. And so we really need to be talking to this population and our patients about what they can do on an individual level to protect themselves. And so one of the things that I think is most powerful that we can do right now is to take an environmental and occupational history. The occupational environmental history, I feel like sometimes people can think that it's really burdensome or can take a long time in clinic to perform. But it really can be utilized to work for any type of clinical setting and any type of patient. On the screen, there is a table with a mnemonic for taking an environmental exposure history. And so all of these parts can be pulled into a clinic visit or maybe just a few depending on the concerns of the patient and, like I said, the clinic flow. And then once we have an environmental history and we have it elicited, a positive response, maybe a lung cancer patient is worried about air pollution, then we need to provide them with risk reduction strategies and resources. And so I'm going to go into those a little bit more. And then I also want to just say that Dr. Wei and I, this is what we do all the time, and I really love talking about this. So we're always here as resources and reach out with questions. We don't really get much of this education in medical school or in other health professional schools. And so as this topic continues to emerge and the literature continues to really point to the negative effects of air pollution on lung cancer incidence and survivorship, I think patients will be wanting to know more and communities will be wanting to know more about how to reduce their risks. So we're always here to talk through that. Next slide. So I think one of the best tools that we can offer patients is the AQI, or the Air Quality Index. And you can click through one more time. Oh, yeah, go back. There you go. I made my slides a little interactive. So the AQI I really like because it is very easy to use and available. The airnow.gov is sort of the landing page for the AQI. The screenshot you're seeing is from that. And it's also very localized, as Dr. Wei nicely laid out. Air pollution risk can be different for different areas of the country, depending on different factors, including, exposure to wildfire smoke and other air pollutants. And so our strategies for reaching patients and protecting communities need to also be localized. And so the AQI is localized, so someone can put in their zip code or their city and find out the air quality in their area at that time. EnviroFlash is another location where you can find the AQI. And this is actually a email subscription that you can sign up for. And so the AQI can come right to the patient or the community member's inbox. Next page. And so the AQI is really usable with this color-coded air quality index, and then guidance on empowering patients and community members to make changes in their daily activities depending on the air quality. So for lung cancer patients who may be just finishing up treatment or thinking towards treatment, they're a really sensitive group, as Dr. Wei nicely laid out. And so it's really important to consider if the air quality is poor, consider limiting outdoor activities or, limiting the intensity of those outdoor activities and watching for symptoms. And then there may be also times when outdoor activities just are not feasible due to poor air quality. Next page. And in those cases, I just wanted to briefly mention that thinking about indoor air quality is really important, and keeping our indoor air quality as healthy as possible. In our indoor air quality, we spend a lot of time inside. And so making sure that it's healthy is really important. And so decreasing some easy tips can be to decrease sources of indoor air pollution, such as candles, air fresheners, smoke. And then on poor air quality days, especially to think about keeping the windows closed and using the AC. Patients can also be counseled to use portable air purifiers and then use the exhaust fan in the bathroom and when cooking. Next page. I also just wanted to highlight, and then you can click through. I also just wanted to highlight a few indoor air pollution resources. So the American Lung Association has really great, a really great resource toolkit about indoor air quality for healthcare professionals. The picture on the screen is an example of that, a decision support tool on particulate matter, or PM. And this tool is really user-friendly for healthcare professionals and goes through what is particulate matter, how can it harm our patients, and then what can we do about it. And they have other tools for different topics around air quality. I will say that this is not specifically focused on cancer patients. There may be unique vulnerabilities to consider around cancer patients, but it is a great place to start. And then one more time, click. And then the EPA also has great indoor air quality resources. This is from their website on making a HEPA filter, a home HEPA filter or do-it-yourself HEPA filter. This is really nice because sometimes the strategies we give patients may be cost prohibited. And so this kind of decreases some of the costs around using a HEPA filter and makes it more usable and accessible for all of our patients. Next page. And then I also just wanted to spend a few minutes on talking about wildfire season, which Dr. Wei mentioned as a really significant uh, consideration when it comes to air pollution. In New York, the wildfire season is around April through October. And so some things that we can talk to patients about include signing up for local alerts. The airnow.gov site has a a section or a link to click on, and they have a wildfire smoke page. And so you can look at where the smoke is coming from and where wildfires may be. And then also for lung cancer patients, consider talking to them, especially around the wildfire season, to make sure that they have all their medications. So if there's wildfire smoke making the air quality poor for a significant amount of days, it may be important for them to have backup refill medications so that they don't have to go out if they don't need to. And also so they have medications if they have, exacerbation or something like that. And then having a supply of masks and 95 respirators if they do need to go out. And then knowing how to close the fresh air intake to the central air system or AC, so it's not pulling in the outdoor air pollution. Next page. And then also in the larger cancer organization sort of literature and in community, there's been a recent call to action to talk more about disaster preparedness with cancer patients because of their unique vulnerabilities. And so there's a number of resources available to this effect, including from the American Cancer Society and from the CDC. And for disaster preparedness, it's recommended for everybody to have a to-go bag like you see in the screen. But then specifically for cancer patients, there's some unique considerations, including around having medications. And so making sure, again, that there's refills, especially if there's, maybe a looming extreme weather event or something. And then also having plans if medications or treatments need to be refrigerated. And so having a backup generator or have another source to keep the medications cool. And then also planning with patients around if appointments may be missed. This area of literature is sort of evolving, and more literature is coming out that natural disasters and extreme weather events can negatively impact cancer survivorship. And so having plans around missed treatments and getting patients back into care after a disaster is really important. And then making sure patients know who to contact and have a list of their key personnel involved in their cancer treatments or their cancer survivorship care. Next page. So that's sort of from the individual level. And then, like I said before, it's really important to consider all different levels to keep patients safe from outdoor air pollution, especially vulnerable cancer patients. And so there's a lot of ways to connect with local organizations and to advocate for policy changes to really protect our air for everybody, particularly for our most vulnerable. And that is, you can go to the next slide. So I just wanted to say thank you so much for having us and for having this really important conversation. As Dr. Wei mentioned, I think this is a very growing field and a really important field, especially as patients are moving into treatment and cancer survivorship and thinking about kind of what's next for them. Having a conversation can be really advantageous around protecting themselves from environmental exposures and outdoor air pollution. And so we're really grateful to be here. Thank you.
Okay, great. Thank you both so much for those amazing presentations. So informative. We're just going to go to some questions that have come in. And I know that you touched on some of these areas, but one of the questions is whether what is the most important thing that clinicians can do today to incorporate environmental exposure science into patient care, given that the evidence is still evolving. So, Dr. Thompson, why don't we start with you?
Yeah. I think that's a really great question, and I definitely acknowledge that there is some nuances and challenges to thinking about, epidemiology on a population level and translating it down to patients. And so I think that is a great thing to acknowledge, and I think we are learning more. And so I think one of the things that we can do, first of all, is just start asking patients, asking if they're concerned about it, asking what they know about things. And as I mentioned, in environmental exposure history, I think some people are hesitant because it can be a big task to take a full environmental history, but it really can work for you and work for your patients. And so it might be that, somebody is entering into survivorship and we want to sort of know what type of air quality they have. So maybe it's incorporated into their HPI as we would ask other questions. Also, environmental health history can also be used as a screening tool. So, it may be turning up to be a wildfire season soon. And so you want to ask patients, do you have a plan if wildfire smoke comes? Do you know what to do? And so it really can be used and tailored to the needs of the patient population. So I think that's one of the first steps. And then I think the AQI is a great place to start because it is so user friendly, and so providers really can access it on and tell patients to access it on their phones or their emails. And it is so user friendly in terms of the color coding. So there's not a lot of kind of background environmental knowledge needed to really be able to make some informed choices around your outdoor air pollution.
Sure, that makes sense. Dr. Wei?
I agree with Hannah. I think for clinicians or healthcare providers, first of all, we should remind our patients, actually not just patients, but for general population, we should improve our consciousness, and we should monitor our local air quality and be aware of the pollution episodes such as wildfire smoke. And as an epidemiologist, I think for me, or for us, I think we should provide more robust evidence. Currently, most evidence are associational, and I think the causal evidence will be more robust. And because if we believe there's a cause and effect relationship, we should be able to predict the outcome given the exposure. That is more, I think more strong evidence to inform our patients and the public.
Okay, thank you. So next question is, if patients have the means to move or change jobs due to air quality concerns, would you recommend that? And in cases where people can't change where they work and live, again, I know you sort of touched on this, utilizing air purifiers inside, et cetera. Are there any other suggestions you have on reducing air pollution exposure?
Yeah, I can start. I think that's really tough because something that we talk about a lot, environmental medicine, is just the stress of it too. And I want to acknowledge that because when people think of environmental exposures, we want our environments to be safe. And so when we don't feel that they are, that can be a really stressful event. But I really want to kind of hone in on empowering patients that, we really can take steps to decrease our air pollution exposure through, checking our AQI and making changes based on that, and then keeping our indoor air quality as clean as possible. And so some of the tips that I mentioned are simple, but can be really, really effective. in protecting our indoor air quality where we do spend a lot of time. And so I don't know if it needs to be, changing jobs or careers, but I do acknowledge that it is just so stressful for patients. And so talking through some of that stress, I think, can also be really, really impactful for patients, and then providing them with these resources and these steps to really empower them and make choices about their environment.
I agree. I mean, I'm not sure if moving to a place with cleaner air would be the best option, because the even for lung cancer, it's really a whole environment. They all matter. If you move to a new place, do you have a comparable healthcare service and other environmental factors? So I think the best way would be reduce your air pollution exposure. And as Hannah said, it would be very helpful to have a portable air purifiers. And if you have a ventilation system in your home or office or hospital, that will be also very helpful. But one thing I want to mention is that, for example, Hannah gave us the example of the homemade air purifier, right? But those filters can only filter out particles. Another important type of pollutant is gaseous pollutants. For example, ozone and nitrogen dioxide from the vehicles. Those are gas. Those filters cannot filter out gas. So now there are some portable air purifiers can have both the HEPA filter and activated carbon filters, which can filter out particles and gases. So and they are now more affordable. So to have more comprehensive protection, I would suggest to have those.
Okay, that's great information. So I'm going to sort of combine these couple of next questions because they're related. So one part of it, and perhaps this is for Dr. Wei, do the data in your analysis reflect U.S. wildfires only, or does it take into account wildfires crossing borders, like from Canada? And the other part of this would be whether there is a difference between that you see in studies between wildfires in rural locations versus more developed or urban places.
The wildfire smoke modeling did take into account the wildfire from the other countries, for example, from Canada. And from that analysis, I think we I don't remember, but there might be some difference between the health effects from urban and rural areas. And there are a couple of reasons. One is the composition of the wildfire smoke. For example, in rural areas, there are more carbonaceous contents because it's mainly the emission from burning of wood. But for urban areas, there may be more metals because the fire burns out the properties. So and also another reason for the potential difference is a disparity. The healthcare, education, it's a systematic. So there are a couple of reasons for the difference.
Dr. Thompson, do you have anything that you want to add to that?
Well, that makes sense. Yeah, I totally agree with him.
Okay, great. Okay, the next question. So it says, can you talk a little bit more about the do-it-yourself HEPA filter? Do they work, and how do you make it? And I think, yeah, let's go with that.
Yeah. So basically it's like a fan, a box fan, and then you can put a filter on top of it. So as Dr. Wei mentioned, it's not, perfect, but I really think it increases the accessibility of some of these HEPA filters, which can be cost prohibitive to, everybody. And like I said, the EPA has a really good resource on it, as well as there's some other sources that you can find that if you just Google it, and I'm happy to share our slides and share these resources with everybody as well. But yeah, it's pretty simple to make, and then you just have to make sure that you're changing the filter according to the filter instructions.
Right. It looked like it was sort of a large how would you
Box fan.
yeah, it's a box fan, but the filter, how would you describe what people are looking for? And obviously they should go
Mhm.
to the website in order to
Yeah.
get more detail on that. Um,
Yeah, I can I just share? Can I put it in the chat? I don't know if you can see that.
yeah,
This is the link to it.
okay,
Yeah.
that's great. Thank you so much.
And so on the link it has the filter suggestion and then how to like clamp it and put it on. Yeah.
Okay, that's great. The sort of as a follow up to that as well. The question is, what can health systems do to better protect communities that are low income or lack access to healthcare or are otherwise vulnerable? Obviously, something like that is one possibility. Do either of you have anything to add on that topic?
I think it's a multifactorial. As I said, it's really systematic. I think first of all, from sources, uh, more pollution sources are located in the more disadvantaged or rural areas, and also for the community itself, uh, it's really systematic. We need to improve the education system, the healthcare, the income, and um, right, and social support. So yeah, and more attention resources should definitely be placed on the disadvantaged communities and populations. Yeah.
Yeah. Yeah, and I think some of the resources, like checking the AQI and the do-it-yourself HEPA filter are more accessible, but I totally agree that it is a larger systemic problem that really needs to be addressed on multi levels. And I think also, as much as healthcare systems can spend resources on disadvantaged groups, I think can be really beneficial and doing the research too, and having that sort of access is important as well.
Okay, so we only have a couple more minutes, so there are a couple more interesting questions. I want to see if we can do like a quick little lightning round and cover like two or three issues really quickly. Um, so one is, why is the PM 2.5 in wildfire smoke more toxic than other kinds?
Well, the wildfire smoke, the smaller the particle is, the more dangerous because it can more easily get into our body. So wildfire smoke, PM5 is is smaller, and also it has more carbonaceous and metal components, which are more toxic. The short answer, that's a short answer.
That's great, thank you. Similarly, can maybe Dr. Thompson, you can make a comment about gas stoves and advice as to that.
Yes, yes, can be a source of indoor air pollution. And so ideally, it would be great if we could not have them in our houses, but a lot of people in New York City have gas stoves. I have a gas stove. And so using other ways to ventilate when you're using the gas stove can be really beneficial, including opening the window or using the fan on top of the stove to try to pull out some of the air pollution.
Yes, I even saw something that said try to cook closer to the fan if the fan is towards the back of your stove, for example. I
Yes, that's a great tip.
about that. And then finally, there were a couple of comments about the AQI not fully accounting for all harmful pollution, such as living near a toxic facility. Are there other measurements, or how would you counsel people to better understand or utilize the AQI?
Yeah, that's a great fact. I think it's a good place to start. I think that is sort of we can't control all of the different sources of air pollution and a factor in them all. And so it's a good place to start and being, cautious and, using the color coding to really fit yourself into what group you fit into and making the needed modifications in your lifestyle based on it. So I think it's a good place to start, but it definitely has its limitations.
Okay, that's great. Dr. Wei, any last comments?
I think, yeah, in addition to AQI, I think PM2.5 itself is a good indicator of the quality, local air quality, because PM2.5 is so far the most dangerous air pollutant based on existing evidence. So both AQI or PM2.5, both are useful, I think.
Okay, very good. Okay, well, so I think that we are going to wrap up here, and I just want to thank Dr. Wei and Dr. Thompson for sharing their expertise and insights with us today. Thank you all for joining us throughout this webinar series. We will drop the evaluation link into the chat, and we'd love to hear your feedback. Thank you again for being with us today, and we hope to see you at future Institute events. Have a wonderful afternoon.
Thank you.